Well, good evening. Tonight we're going to go ahead and do our last PowerPoint. This is liberation. This is taking your patient off the ventilator if possible. There's three different categories of weaning. We all talk about weaning. One is the quicken, the routine one. Remember, we talked a little bit about this on Monday. Sometimes your patients are only on for a very short period of time. They're awake, they're ready to come off, and we can just basically take them off. If they've been on a longer period of time, more gradual reduction sometimes needed. At this particular point, we have what we call spontaneous breathing trials that we run. Tells us whether or not it's going to work for us. So we have to watch these patients and make sure that they're getting stronger so that they can actually be taken off the ventilators. And unfortunately, we also end up with vent-dependent or unweanable patients that we're not going to be able to wean for any variety of reasons. So how do we know a patient's going to be ready? Well, first of all, they have to be spontaneously breathing. If they're not spontaneously breathing, all bets are off at this particular point. They have to be able to manage their secretions, protect their airway. If they cannot do this, all bets are off at this particular point. So the question comes up sometimes, well, what are you going to do with a patient that cannot protect their airway and manage their secretions? When we don't want to leave them intubated for the rest of their lives because they're strong, they're back to where they need to be. One thing to think about is that you may end up having to trach these patients. And then you remember, if the airway is okay at this particular point, once it heals, then we could possibly pull those trachs. Is the patient going to meet the weaning requirements? Remember, when we started, we talked about the fact that whatever puts you on the vent takes you off. All you do is change your signs. So we're going to look and see, do we have the respiratory criteria that we had at one time? How about their cardiovascular status? You know, is their heart beating appropriately? Are they having an MI? If they are, we're definitely not taking them off. Mental status, sometimes we don't realize a patient has really stroked until we start to pay more closer attention to them. And if they're unable to follow what we need, unfortunately, sometimes we're not going to be able to do too much with them either. And then make sure that there's nothing else that's going on in the background that's going to cause us some problems. So why do people fail weaning? Well, one is that the workload or demand exceeds what the patient is capable of doing. And basically what we see is an improper balance between the ventilatory needs and the neural cardiorespiratory capacity. Sometimes increased ventilator workload or demand may exceed what this patient actually can do. And if this is what's happening, then these patients are not ready to come off the vents. So what are some of the things that cause our patients not to be able to be weaned? One is your workload, the level of ventilation that's required. If you've been on assist control for a month or so, you're probably going to have a little bit longer time trying to get off the ventilator at that point. Do you have anything going on with your lungs or your thorax that's going to interfere with you effectively breathing? Do you have airway resistance? Sometimes we can remove this resistance and see how you're doing. In post-workup breathing from the circuit, etc., how do we overcome this? Remember, we talked about pressure support ventilation. Pressure support helps to overcome all of these resistances. Goes on live. Ventilatory capacity, we're looking at the central nervous system. We're looking at the muscle strength. We're looking at muscle endurance. If your patient can't be weaned, once they've passed the acute stage, we move them out of the acute care facilities into our SNFs, the skilled nursing centers, long-term rehab centers, whatever, at that particular point. Other things we want to look at is nutritional status, electrolyte balance. Remember, you have a lot of the electrolytes you have to keep an eye on, especially your potassium, especially your phosphorus, things along that line. Is there auto PEEP? If there's auto PEEP, how do we correct that? Because they're going to have an increased work of breathing with that one. Have they picked up something secondary? For example, is there now an infection going on? Or have we found out that they actually have some organ system failure happening? And if they are, they're not going to be able to be weaned. If they have left heart failure and this is new, or left heart failure that's actually gotten worse, there's a good possibility we're not going to be able to get them off the ventilators either. Other reasons we don't think about, they could be in the middle of an MI. This has happened before. There could be some neuromuscular dysfunction. We cannot do anything with their oxygenation. Do they have a low H&H? If they do, then sometimes we have to look at that. Are we going to, the physician going to give them a transfusion and try to go ahead and take care of it? People sometimes feel very comfortable on ventilators, and if they do, no matter what we do, we're not going to be able to get them off. Is there CHF going on? Is there pulmonary edema going on? Is there a tracheal obstruction? Do they have tracheomalacia? Do they have tracheal stenosis? Is there something else that's happening at this particular point? Hypothyroidism is another one. Have these patients been able to sleep? Are they in pain? Okay. Do they have something metabolically going on that we haven't taken a look at? And although folks don't understand why, but sometimes the timing of the tracheotomy will also prevent these patients from being weaned. A lot of the research they're doing on this to try to figure it out, unfortunately, I don't think we still have quite figured all that out. So chronic ventilator dependency, if you have chronic COPD in some cases, remember some of your neuromuscular diseases, these guys are on ventilators at this particular point. Other muscle weakness found only in your ICU patients, your critical illness, polyneuropathy and myopathy. We don't want to overfeed these patients. We're going to increase their workload if we do. We want to, like I said, look at the electrolytes. Let's look at everything going on with this patient. Other times what happens, patients to the point we think they're ready to be weaned, they need to be off the ventilators. If we can, we'll go ahead and take them off, and we'll go ahead and put them on BiPAP and see if that will help them get stronger and stay off the vents. So what makes it easy for us to take a look at? We have weaning parameters, okay? Has the problem to put them on been resolved to the point where they can now handle whatever's going on? If you have a really bad pneumonia, you're unable to breathe, you're not going to be pneumonia free when we take you off, but you're going to be to the point where you can handle it. Have you returned to at least where you were when prior to being placed on a ventilator? Okay, we look at your workload, your capacity, your oxygenation status, again, the cardiovascular status. Are your other systems working? Have you gone into acute kidney failure? At one time, acute kidney failure was tied in with ARDS, and what we used to think was that ARDS caused acute kidney failure. We now know that's a separate thing that happens by itself. So we need to know what's going on with that. And then the duration of the ventilation. Really, how long have you been on here, and what do we need to do to get you off? So with oxygenation, we're looking for a PaO2 greater than 60. We'll take sometimes greater than 50 for COPD. We want you on an FiO2 somewhere between 40 and 50%. SaO2 greater than 90. There's your 60 millimeters of mercury for the PaO2. SvO2 sometimes less than 60. Remember, 75 is considered to be normal. Sometimes we like something better. Your little a to big A ratio should be greater than 0.35, and your QSQT should be less than 15 to 20%, and hopefully no lactic acidosis. Remember, with lactic acidosis, you're producing a lot of pyruvic acid also, and unfortunately, your muscles are going to tire out. So on the ventilatory side of the house, normally if your respiratory rate is above 30, 35, that's a sign of respiratory distress. You're not quite ready to be weaned at this particular point. Apnea, apnea, apnea. Remember, if your patient has apnea, they are a candidate to be placed on mechanical ventilation. If that apnea continues, we're going to have problems. Asynchronous breathing pattern, that's your respiratory alternates also, not a good thing. using accessory muscles, having retractions, way too much work of breathing. One or two signs, sometimes your physicians will say, let's go ahead and do it. 3 or more, you do not want to be trying this because your patient's probably not going to do extremely well. And then we want the CO2 less than 50 with our pH greater than 7.35 at this particular point. So the ventilatory mechanics, remember, we want a tidal volume greater than 5 mLs per kilo, vital capacity greater than 10. Like I said, we're seeing some of the literature coming back to the range of 10 to 15 mLs per kilo. There's your respiratory rate less than 35, static compliance greater than 25 mLs per centimeter of water, RSBI less than 105, and then can they breathe around the tube? In some cases too, what they're doing is they're getting these folks up and they're walking them around the ICU. They have to push their vent around. This is something that was done in the early stages of mechanical ventilation. And what we're doing now is revisiting that. So some of the weaning indexes have changed a little bit. Some of the traditional ones, we're looking P to F. Remember, anything greater than 200 you're considered as a candidate for weaning. Your PA minus little AO2 gradient, if you're 100% oxygen, less than 350. Your MIP, your NIF, is at less than -20. Do you remember in some hospitals they actually go up to -25, -30? What is your vital capacity, spontaneous minute ventilation, your MVV if they do that? Newer ones, RSBI seems to be one of the favorite ones that we have out there. Remember, RSBI is taking your respiratory rate divided by your spontaneous tidal volume in liters. Your P0.1, this is the first 100 milliseconds of inspiration against a closed system. And, if you can do that, you're ready to do it. And then we can look at the measures of your work of breathing. So there's your MIF-NIF, as we said, less than -20. Some hospitals are going much, much higher than that. Minute ventilation, less than 10 liters per minute. Your dead space, less than 60%. There's your P0.1, less than 6 centimeters of water pressure. And if they do the MVV, it's the reverse of what put you on. So again, just continuing support. What is the workload? What is the capacity? What is their oxygenation, okay? How's their cardiovascular function? And are they waking up? Are they responding to what we're doing? And so what we're going to do is we're going to sit back and watch them and then see what we can do to help them. The key to this is you don't wean to exhaustion. If your patient's starting to tire out, well, how do I know my patient's getting tired? Well, one of the things we're going to see is their heart rate go up. They become restless. As long as they become restless, sometimes they could be becoming hypoxic or hypoxemic. So we want to watch the oxygenation portion of it. We want to see where their CO2 is going in some cases. So if there's a change in their appearance, and especially if they're not looking extremely well, then we need to take a look at those and try to figure out what's going on at this point. Other things we want to look at, we want a normal acid-base balance. We want to make sure they've had some nutrition. Remember, we're not going to feed them straight carbs. If we do, that has an RQ of 1. That means they're going to have to work harder to get rid of that excess CO2. The metabolic rate, they're not extremely active, that they're still doing okay. Where's their renal function? Where are their electrolytes? Again, cardiovascular, psychological factors, and protecting that airway. So what are we looking for? Best of all worlds. We want everything to be the best it can be for this patient. And the thing is we're going to talk to these patients and we can talk to the families and tell them we need your help. One study they did, they said up to about 47% of patients on event 5 or more days have psychological problems. And the question is why? And it's really kind of things we see and we've talked about. A lack of sleep, the drugs we give them, the stress these patients have because they don't sleep, listening to the noise. The ICU is a closed environment, so whatever's going on in there has a tendency to stay in there. We need to make it more comfortable. One of the things you'll see in the ICU is you can't have plants. You can't have plants because you don't know who's allergic to them. But you can have pictures of your family. You can always sneak your puppy in as long as you don't get caught. Okay? Um, Move the patient around, sit them up, let them see what's going on. Part of the VAP prevention, remember 30 to 45 degrees is where you want the head of the bed. Well, see if you can get them up higher, put them into a high Fowler's. If they have what they used to call the Cadillac chairs, we would take them out of bed and we could move them around, and these folks did extremely well. You have to talk to these patients. You have to tell them what's going on. You have to tell them what you're doing and what you want. You have to make them feel they're part of everything that's going on. So how do we liberate patients? We used to use tube trials. We would sometimes take these patients off ventilators, hook them up to large volume nebulizers, set the FiO2, make sure things were going okay with them. Problem with the tube trial, they were off the vent, there were no alarms. And so you had to have somebody there constantly monitoring them. If the nurses were over in that area and they weren't going away, they would keep an eye on them. Unfortunately, sometimes, especially if they have another patient that's high maintenance, these patients, we cannot leave them alone. We need to be working with them. Pressure support ventilation, remember we're in the process of turning that down, making sure that their tidal volume remains well and that they're not getting anxious and that we're not seeing an increase in their respiratory rate. SIMV has sort of been kicked up by the wayside, even though you may see this on occasions. Some of the newer things we're thinking about, the spontaneous breathing trials, the awakening, the sedation vacations, different things along that line. Now, spontaneous breathing trials, we're seeing more and more of those. And basically what we're doing, and we can leave these patients on the ventilator so we have a backup. We also have the alarm. And these can go anywhere from 30 minutes to 2 hours. And so normally what happens is we'll take the patients and put them on CPAP or basically CPAP. We can add some PEEP to it, give them maybe 5 a PEEP. Pressure support, maybe 5, 6, 7, sometimes 8. See if that helps them any. At the end of the time frame, depending on what your physician wants, a lot of times we'll put them back on a rate and then we'll do an ABG and see where they are at this particular point. Then you need to talk to your physicians and tell them, hey, Mr. Jones is really, really antsy. He's trying to pull his tube out. He's really moving all over the place. I think he's quite ready to come out. And we're going to find out that sometimes we're probably a better judge of when these folks are ready to come off the vent at that particular point. So how do we get them ready for a spontaneous breathing trial? P to F has to still be greater than 200, the PEEP less than 5. Pressure support, depending, sometimes your pressure support, they'll tell you has to go down to about 5 also. Just depends on your physician and your hospital protocols. Intact airway reflexes, and you don't want them on a continuous infusion of vasopressors or inotropes. They have to be able to be moved. They have to be able to get up and not be tied to that bed. So we want to take them off when they're much, much better at this particular point. So what are we going to monitor? There's your respiratory rate and pattern, your PaCO2, oxygenation, anything you need to put on with that one, heart rate, blood pressure. If you start to see their blood pressure go up and their heart rate go up, your patient is not ready to be weaned. You need to work with them to calm them down. If their respiratory rate's up in the 30s, 40s, and 50s, you need to go in there and calm them down. Just don't give up on them right away. Work with these patients If after an extended period of time, 5, 10, 15 minutes at the most, you still can't do anything with these patients and things are getting much, much worse, stop and put them back on their rate and put them back on what they were prior to starting this trial, okay? And get them calmed down and relaxed. Maybe they need just a teeny tiny sedation, not a whole lot, just enough to take that little bit of an edge off. And we're starting to see more and more of that being done in our intensive care units. So finally, there's no tracheal stenosis, there's no tracheal malacia. The patient is awake, they're listening to what's going on, things are working out, there's no GI bleeds, no cardiac events, everything looks really pretty good. The disease process is resolving beautifully, they're hemodynamically stable, no sepsis, they have adequate oxygenation, good pH, wonderful PaCO2. We're ready to pull the tube. We're going to extubate them and then liberate them from mechanical vent. And there you can see a happy puppy. So does this mean that we just sort of walk away and leave these patients? Well, the answer is no. We need to assess them for bladdic edema and stridor. We need to see what's going on with them. If we're starting to hear stridor, think about your steroids, racemic epi, cool mist. In some cases, if the stridor gets worse, you need to be on the phone with your physician because they're probably going to have to be re-intubated at this particular point. Heliox on occasions, we may use that. Just depends on whether or not you have it available at the time you take these patients off. If they have an impaired gag reflex, impaired cough reflex, now we got a problem because we're going to have to definitely keep an eye on them. One of the things we're really good at picking up is when the patient is unable to protect that airway as well as they need to. And how do we pick up on this? Basically what we do is we go in there, they may have some ice chips and they may be choking on the ice chips. And so if they're choking on the ice chips, we need to get a swallow study. We need to tell the nurse that the patient needs a swallow study to make sure that they can swallow and not aspirate and end up with some additional problems. So happiness is being off your ventilator. True freedom is being liberated from your ventilator.